Thank you very much. So great to be here, and sorry about all of the audiovisual stuff. It's probably some of my fault for putting some of this stuff in an unusual format. But we're going to talk about digital twins for emergency care, and I'll just go ahead and start. These are my disclosures. I'm going to move quickly. So by the end of this, I really want you to kind of understand what a digital twin is and be able to define it. And then we're going to talk a little bit about some of the evaluation kind of metrics and things to look for within this. And then finally within that, we're going to talk more about kind of identification. And I should start by just saying that from a standpoint of like, why do you think, like, why digital twins for emergency care? And it's really this kind of issue about us moving into agentic workflows in the future with AI being embedded within the healthcare systems. If you think about it, there's a lot of problems with that type of kind of introduction from a testing standpoint. And we're going to go through a lot of those things. That's what started getting me thinking about it. Actually, the question really arose when I started thinking about how do you do value representation within organizational structures, and how do you disseminate that to agentic workflows, and then what does that look like from a healthcare standpoint, and then what kind of problems could you run into, and how would you test that? I wanted to touch on those 3 points within this. So the kind of narrative arc is going to be from an educational perspective, from a human-AI interaction perspective, and then also finally from kind of an agentic workflow perspective. So the traditional kind of workflow or kind of process from an educational standpoint when you come into medicine is you do a lot of reading. That's like your first 2 years of medical school. Now they've introduced a lot of like simulation within that environment. Then you do some type of supervised practice, and then finally you do independent practice. The problem with this from an AI perspective is you may read a little, some about AI and what that means for medicine, but it's very unlikely, at least at this point, that you're going to get a lot of exposure to AI embedded systems within the healthcare environment. And really, from a testing standpoint, you're going to get very, very little. Most of the time when these things are being introduced, they're coming from the third-party vendor. One day it's not there, the next day it's there, and then you have to figure out like what you're going to do about it. So obviously that's a problem. It would be nice if we had systems to help us with that. The second part about this is with the development cycle. If you've been in the healthcare space and you're thinking about designing some type of AI tool or clinical decision support tool, you'll notice that usually the timeline around this, it starts at like design, and then you go to like some IRB. That process can take multiple months, and then you go to some type of integration. That process also can take multiple months. You do some type of piloting. Usually we do that in like silent mode. And then you go to some audit process and then continual kind of deployment afterwards. That takes a very long time. I really worry about it even from like a grant writing standpoint, because you write a grant, you have this 5-year time frame around that, and maybe you get the grant, maybe you don't. But the development process around this takes forever, and as we all know, like AI, machine learning are moving really quickly, and it's too slow. Ideally, you'd like to be in this type of scenario where you can do this rapid A/B testing within an environment, and you continually kind of improve until you're happy with the kind of interaction. And that's interaction with providers in various different contexts, whether that's nurses or physicians or patients within the healthcare space. And then the third part, and probably the real origin behind this, and I mentioned previously, is thinking about like what does this look like as we move forward and we have more autonomous systems that are within healthcare. And if you don't think that this is already happening, if you haven't been paying attention to what's going on in Utah, where they're doing AI prescribing for patients at this point without really any physician oversight. It's for chronic medications, but there was some regulatory loophole around that. We are moving into that direction. There's a clear financial benefit for addressing these things in various different ways. But the problem with this, you can't see it very well in the diagram, I think, because of the lighting. But it's hard to think about like how do AI like agents, as they're working within a system, how are they really monitored from a safety aspect within this process, because they have multiple decision points within this. There are lots of colliding and different effects. And so, that looks like a lot of different things. We can see emergent behavior with these AI systems. You can see cascading side effects. We have an AI agent that's managing somebody's diabetes, but it has a limited resource pool, and then it starts to pull medications away from somebody else. You have this issue around value trade-offs. The classic thing that I say in the emergency department is around knee pain. Somebody comes in, they've strained their knee. It may be that they need an MRI, but from a cost standpoint, it's probably not best that they get an MRI in the emergency department. So, that's a decision that a doctor needs to make with their patient. You can think about how do you instantiate those types of things within autonomous systems? How does it weigh all those different values and belief streams? The multiple kind of agent interactions and components within this. You have complex branching. We all know that healthcare has a lot of decision points. I read somewhere recently that emergency doctors make about 25,000 decisions within a typical 8-hour shift. So it's a lot. And then there's probably the biggest safety component about this is there are irreversible decisions, right? You make a decision, send a patient home to give them particular medication, et cetera. It's not usually something you can take back, although we have some safety mechanisms in place. So it'd be nice if we didn't have just introduce this into a live environment, that we could put this into something else. And that's really where kind of digital twins come into place. So you can think about a digital twin as really like a computational mirror of a system. And the idea, and there's very strict definitions that come from in the healthcare space that digital twin needs to have this bidirectional flow to it, where you're taking information that's coming from the system, you're moving it into the digital twin, and then you're moving it back into the system to make decisions. We're not there yet from a healthcare standpoint. But that's kind of the general idea. So, you're either mirroring somebody's heart, you're mirroring the whole entire healthcare system. In this context, we're going to talk about what it looks like from the EHR and the ED space. If you don't know a little bit about the history of digital twins, it's kind of interesting. In 1970, this really kind of originated from NASA when they were thinking about space flight. They actually built out a twin system for a lot of the kind of hardware that was on the spacecraft at the time. That allowed them to be able to troubleshoot, with the twin before they made any recommendations within the spacecraft itself. The concept of it moving into a digital space happened in 2002 with a lot of kind of management aspects of things. The aviation industry has moved into this space around 2012. They started looking at this from kind of the plane infrastructure and how much strain was ongoing within the plane infrastructure and how they can model that within a system. And then in 2018, there were some kind of taxonomies and definitional aspects and changes. And I should state probably what we're going to talk about today is more of a model at this point than a true digital twin. So a model would be, you take data from a system and then you have a model that's not doing a lot of pushing back in. A shadow would be, that where you're actually pulling out real-time data and then you're making some decisions. And then a twin, in their strict definition, is that there's a bidirectional component to it. You would take that information and then move it back into the system. And then, and finally, I think in 2025, healthcare kind of recognizes as a big movement, and there's a lot of kind of reports about, what that would look like in healthcare as we move forward. So the basic scenario in the clinical space is that we have clinical scenarios that are ongoing all the time. These are captured within the electronic health record that serves as our data store. Then we can move that physical data into a twin, or we can do validation components against the twin. The twin is meant to represent whatever system we're talking about. In this case, it'll be the emergency department. And then there's an interface a lot of times on the top of this. The other thing I had mentioned was that there's really a couple of levels that you can think about these twins from. So in the healthcare space, a lot of the kind of initial twins were around what I would call organ-based twin systems. So probably the living heart example would be the probably most prominent within that. Then you can think about it from a system standpoint. That system could be a patient, or it could be some other component of the healthcare process. And then lastly, you can think about it from a population standpoint. And that's where I kind of think you are once you really kind of get to like modeling in a complete emergency department. Okay, so the problem with this is that, at least in the healthcare space, a lot of times when people say digital twin, and I'm going to self-admit, I think we're not there yet either, is that they're not really running digital twins kind of under the strict definitions. There's not a lot of verification and validation. They've done that kind of first step of building out some type of modeling system, but are they really looking at it from a validation standpoint? Are they really looking at it from a kind of a heart performance standpoint? The number of hours that is required and the computational resources that are required for a lot of these systems is pretty significant. If you can think about like modeling a neonatal kind of ICU and what that would look like at the very, very granular level of representing patient physiology all the way up into the full ICU, it can be very challenging. And within the emergency department space, there really are no trials, and really, frankly, not even really any papers that are kind of describing this overall process. We've had operational kind of simulations in the past, but not what I would call like really twin type scenarios. So what I'm kind of proposing is that there are really like three gaps we're trying to address. One is this rehearsal space or kind of educational pedagogical space. The second is this development environment. And the third is kind of this validation aspect, or looking at ways we can do testing within the digital twins. So I'm going to transition and just now start talking about building out the laboratory around this. So what do you actually need within this? You need some way of representing patient physiology. I think right now, a lot of times these are built with rules-based systems underneath. So if I give an antibiotic to a patient and they have sepsis, I would expect some type of change, or if I give fluids and so on and so forth. I really think in the future, this is all going to be done with foundation models. We are already doing a lot of work. I have a lot of collaborators at Yale that are already doing a lot of work with doing like multimodal foundation models that are able to represent these systems pretty well. But right now, that's a particular challenge. You also have to think about it from a patient representation. Like, how do you get to authenticity from the kind of patient experience, particularly when you're thinking about it from like an educational standpoint. So if I want to run a simulation with residents, with medical students, with faculty, it really needs to feel like an authentic experience. And some of that stuff is captured in real-time data. You have patients' ages and all that stuff. But other things that are kind of the nuanced attributes of what makes us who we aren't really captured. So if you can think about the way that you speak, how you interact with people, whether you're angry that particular day or not, like that stuff is not really captured well within the system. Maybe one day when we're doing complete audio and kind of video and everything else, ambient listening within systems, the healthcare system, I think maybe we'll be able to capture some of that stuff, but you need to be able to kind of represent this now. And so we do that synthetically with a lot of kind of variation and randomization and what the patients would present with. And then you need to think about what are the kind of interactions that happen within the system, like who are the players that happen within the emergency department. And so we've conceptualized this is that you basically have agents that are representing all of these different types and components. You need to be able to model effectively what the flow looks like. This is where I think domain expertise really, really helps to kind of map out all of this process. It also helps to have underlying operational data to know how this kind of process map happens within that space. You need to be able to then also to look at resource constraints. So, it needs to be the case that if I have two agents that are representing a physician within the system and they both order a CT, roughly simultaneous, how do you make a decision about what patient goes to the CT scanner next within the system? So you need some way of kind of monitoring and regulating that. And a lot of times this is done through some type of rules or policy-based component within the system. So for instance, many of you may not know, but from a nursing kind of staff ratio, nurses are only supposed to take X number of patients. So if we have 10 people in the waiting room and one nurse already has 6 patients, there's an open bed, but they're from a policy standpoint, they're capped at 5. from a policy standpoint, we should not be giving that nurse an additional patient within that. And you need to be able to capture that within the system and be able to deal with that. The nice thing about that, it also allows you to be able to test policies as you move forward. Like, what if we change that policy to 7 patients, 8 patients within the system? So we modeled this in various different ways within the system. So it has an underlying physics engine that creates a kind of a world state that has underlying physiology. We have patient personas and scripts that are generated. Those we started with kind of just synthetic data. We are now using EHR data to then inform those personas so that we have real representations. Because you might look at a persona and say, oh, that looks like a patient in the sense that they have the right past medical history and maybe the right medications. But most of the time when I look at it, I'm like, oh, it looks fake. And so there's some like intangible aspect I can't necessarily describe, but it's definitely there. And so it really helps to have real world data to help inform these things. And it gets closer to the idea of a digital twin. A thing that was a big challenge within this was thinking about scheduling of all of the agents as they move through the system. So if you have one agent that's the nurse that's interviewing the patient for triage, you have another agent that's representing the CT scanner tech, you have another agent that's representing the physician. You need to be able to schedule how that process is handled within the overall system. And another thing we had to do was kind of figure out how to do delays and like heavy computational things within the LLM systems as well. So if there's some task that gets posed to the agent, like for instance, like writing a detailed script or note around the dialogue that happens, that needed to be kind of pushed to the side while other processes went on so that we wouldn't kind of hang up the system overall. So I'll actually, just from time standpoint, I'll skip over this. This is just looking at one round of the simulation. And it's just walking through like what gets pushed. And the basic idea is that you have what in this thing it's called like dirty boards. I don't necessarily like the terminology around that, but they're basically a task list that gets popped up, and then there's a scheduler that kind of figures out who and what is supposed to be doing next within the task standpoint. Okay, so this is going to be the challenging part. I want to show you all this, and so I'm going to run up here because actually let me figure this out. Actually, can you do me a favor with the mouse? Can you just click on the autonomous sim part? Great, and then just click a launch demo. Great, okay. So it's working great. Okay, so this is the sim environment. We tried to be as high fidelity as possible with the way that the EHR looked. And again, and all of this was to make it feel from a kind of a authentic standpoint for the residents and from an educational standpoint. What you'll start to notice is that some patients got initially arrived within the system, and then now it's going into there's a scheduler. It has background physics. It's supposed to tell you how many patients are arriving per hour within the system, and then it starts the overall process. There's a nurse at triage that once the patient gets moved into a particular triage room, they will do the triage process within that. And you can see down here like what it's waiting on. So there's kind of an event thing. The time up at the top, you see it starts at 7 o'clock in the morning because it's a typical start to an ED shift. So now it's 7:28. So vital checks are being redone, procedures are being ordered for some patients, and then you can see there's 6 LLMs or agents that are in flight at this point, and then there will be some holdup as they're making decisions within the overall process. If you can now advance to the next slide, what I've found in the past, if you click at the top and then it'll allow you to be able to go to the next, there you go. Okay, great. And then just move one more forward. So I'm just going to walk you through a little bit of a demo. If you can click on the interactive walkthrough really quickly, and you can just start session. Great, and it should fire up. Okay, so I went ahead and a lot of times the way this is supposed to work is it's really supposed to put you at a particular time frame within the emergency department encounter. This, for just presentation purposes, is really just designed to load up a lot of patients at once so that we don't have to wait on the sim in the back. But if you can just click on the first patient, the Charles Perez, just double click within that. Great. Okay. And so I'm just going to give you just a quick walkthrough, kind of the look and feel. So it has the typical. If you've been in an emergency department or if you worked in the system, this is kind of what it looks like. You can go just click on the next tab, the snapshot. So it just has the overall kind of appearance. The vital signs are coming through. If you can go to the dialogue section, that's next. So we're going to try this. I don't know if the voice is working, but if you go and click on the voice mode, turn that on for quickly. Okay, that's what I did last time. That's okay. So the idea here is that as for this particular demo, you're functioning as the physician. So you actually are interacting with the system. This is more of like the educational type environment. You click within it, and then you're able to talk to the patient overall. They have an underlying persona that they know, like they're supposed to reflect their disease process, but not tell you obviously that like they have appendicitis or something else within that overall. And then if you go to orders, just real quick. And then just click on any order on the other side. So the other way this works is it has the full functionality and the feel for what it would be like in a real emergency department. You place orders, you can come over here and sign the orders. Those will then get put in the queue. The way that we handle this from, because you don't know what people are going to necessarily order within the system, is that you have an LLM that's aware of the overall patient persona, their disease process, and everything else. And if you ask for some random lab, then the LLM just makes a determination about what that would mean for that particular patient under that persona. I think then we can jump out real quick from this real quick. Yeah, just same thing as you did before. Great. Okay, so now we're just going to shift gears. I think I'm still okay, relatively on time. You can just click move forward one. So I talked about really three aspects of things. So one was this kind of clinical rehearsal space or educational space. And it's really, addressing kind of this idea that we have, should have some type of consequence-free rehearsal and simulation space to be able to do educational things. You would love to have a situation where you have repeatable scenarios. So even in a kind of a traditional educational simulation space right now, there's going to be variation in the way the moderator does simulation and all of those things. It would be really nice to present the same patients, the same block of patients to all of your residents, all your faculty, medical students, et cetera, and then see how people respond to those patients. And then, the nice thing is because it's a built-in system, you can give them annotated kind of playback and feedback on the way that they were doing things within that. And then you can study things like their kind of interactions and how they felt about things like AI. Next slide. So the aspect of this, is just there's a training loop component. You can skip this. We can go to just the next slide real quick. If you can do me a favor and just click on the sim education. And I won't go into any of these at this point, but the idea is that you would load up different scenarios based upon different educational tasks. So let's say that somebody has some deficiencies in a competency around like cardiovascular care. The idea is that you can then take your cohort of patients that you have that are the simulated patients within the system, load that up into the environment, and then they can walk through those within a scenario. Or you can teach them about mass casualty events and so on and so forth within that space. So that's kind of the idea overall within the sim education space. And then if you can click and then come out again. And the idea would be that you can get really kind of interesting, important metrics on this. So for instance, if you were interested in looking at somebody's diagnostic performance on something challenging, one thing we struggle with, and I'll talk about this in just a second, is in urinary tract infection diagnosis, we're just not good at it because you have to look at the urinalysis results, and you get multiple different data points, and we don't get really trained on what the result is because the urine culture comes back at 24 to 48 hours. But you can look at these things and you could see how the resident would improve in their diagnostic accuracy over a particular time. One of the things that was really interesting to me is that you can look at order efficiency or how well people are being, doing from a cost effectiveness standpoint. This is often a forgotten part about diagnosis, is that ideally, the best diagnostician is the person that can use the limited number of diagnostic tests to get to the right answer. So there's an optimization kind of pathway around that. That's not often how diagnosis is viewed. It's as long as you get the diagnosis, it doesn't matter what you do in the meantime. But and that's one of the reasons why we kind of had that mentality is because we can't really study very effectively kind of the other end of that. But within this, you can easily look and say, okay, these are the same patients, same scenario. This person got to the diagnosis ordering 2 labs versus 20 labs within that process. So there's some efficiency metrics that you can gain from that. In traditional kind of like educational environment, you can look at kind of critical actions and what those look like. And then probably a really interesting component about this is that when you have that kind of physician agent dialogue, you can actually capture all those dialogues and then look at things like communication skills. If you have to give bad information to a patient or something like that. Bad information, I mean, in the sense of like, somebody died or something like that. So really interesting things you can pull from from this space. Next slide. And then, I think the second part about this is we were talking about is like, okay, the development environment, what does that look like? What can you do within that space? And the next slide. And so the nice thing is that you can build really cool like experimental designs within this, right? So I can take a group of residents, faculty members, and then I can randomize them to receiving an AI clinical decision support tool or not, and walk through cases, and then see kind of what the effect is of that tool within the overall state. And then next slide. So what does that kind of look like if you go into just the research section really quickly? And if you just click on the human AI piece, and then just click on the antibiotic stewardship, and then just hit start session really quickly. And then if you click on just the first patient again, great, and then go over to the UTI app. So the idea behind this is that you can embed within this system a AI clinical decision support tool around urinary tract infection diagnosis. The nice thing part about this, if kind of data representation on the healthcare side of things, is that the entire database on the back end of this is represented in FHIR. So when we want to be able to take this and then translate it out into the real world, it's a lot easier because we already have a detailed FHIR representation within that. Okay, and then you can come out of these slides. You mean Firebase? Yeah, Firebase, yeah. Yeah, but it's a FHIR database underneath, yeah, that's set up that way with all the schema and everything else. And so you can do very interesting things. Like this is a cool study environment. You can look at cognitive load. You can look at A/B testing across various different things within this. You can look at people's diagnostic accuracy now with and without a particular tool that's in place. And I mention all of this because one of the things if you work and you've developed within the healthcare space is that it's really challenging to actually develop quickly within the healthcare space. And so this provides an environment for you to be able to do that. Next slide. And then the last thing, and I won't talk about this a lot here just from a time standpoint, but I had mentioned about the agentic flow. So one thing we did was at triage, when patients come into the healthcare system, they get triaged, and then if there are no bed spaces available, they get placed back into the waiting room. And then that's what we call like a queuing process. And then somebody has to make the decision about, okay, now you have 20 patients in the waiting room. They maybe have the same kind of severity of illness score or triage score, like who comes back next into the emergency department. So you could think about it, that's typically now handled by a charge nurse, but in the future, it could be handled by an AI agent that looks over everybody's, basically everybody's a detailed kind of EHR description within the system that's in the waiting room, and then makes a decision based upon that who to pull back. So we started doing some kind of studies around that to look at a lot of this value representation. And what I was interested in was if you run into that scenario where we constrain the number of beds, or we constrain the number of nurses that are there, how does the AI agent react in those types of scenarios? Next slide. And then you can just move to the next slide after that. I'm going to skip over this just to say that for the future, what we're hoping to do is continue to build out various different components of this. Really, what I want to get to is a system where you can port this into a separate healthcare institution. They are able to upload their data in a de-identified way. They then have a digital twin of their environment, and then they can do all of the testing and everything else. and then you can just advance all the way to the end. I'll just stop there from a time standpoint. But yeah, if you're interested, let me know. It's fun to work on all this kind of stuff. And thanks for allowing me to be here as well.
Awesome, thank you. So this room's running 10 minutes late, so if you're trying to get to a different room, probably hop up and head out of there. That said, we have a little bit of time if there's a few questions people want to ask, and the next speaker can kind of maybe head up there and see what our current AV situation is and try to get that sorted.
Just thanks for the presentation. I think it's really interesting. Just the main use case for this is it's more educational or testing new.
So
I just wasn't.
Yeah.
On,
so I think
there's a lot of potential. So I just was.
Yeah. I think there's 3 use cases. Probably from a financial standpoint, there's probably 2 real good use cases. One is the educational. If you can think about it as as a tool that you would then pitch to different educational programs, et cetera. The second part about that would be operational. Pitching is an operational tool. Like, one of the things we struggle with is like, it's a particularly bad day in the emergency department. We have, it's been, I don't know, you think about like the ice storm. You have 1 million people are coming in with orthopedic injuries or something like that. It would be really nice to have a digital twin in the background and say, this is our current state. Like, what if we brought in 5 additional nurses in the next 2 hours? Like, what would our kind of overall process and flow look like? So I think that there's an opportunity in that space. Overall, I think there's this 3 domains, right? It's the educational space. It's really the kind of development space for kind of AI, CDS type tools and building out different types of interfaces for physicians. And then the third is, and probably, the real motivating factor behind this is looking at agentic workflows within this. Like, if I let the agents just run wild within the system, like what do they do? How do they make decisions? How do they interact within that? So it's, all of those 3 things.
I can talk loud.
Yeah, go for it. Yeah, I can too. So.
Okay. No, thank you for your presentation.
Yeah, you're welcome.
Very interesting. So if you had appendicitis or a heart attack,
Yes.
what would you entrust your health to regarding?
Yeah, these are always the core ethical. Yeah, I mean, I would entrust my health to the system that delivers the best outcomes. So if it is the healthcare system and it's AI powered and it's delivering better outcomes, then that's the system I'm going to trust. And honestly, as a physician, my oath is to basically make the decisions that help patients the most. And if it's an AI system that delivers that, then that's, ethically, that's what I feel like I have to accept.
So I'm going to ask one more question.
Okay, yeah, sure.
So allowing AI into medicine can help with speed and consistency, but the main problem is that it can make care feel less human, like less personal, less morally accountable, less human. How do you address those risks? Like reduced empathy, weaker patient trust?
Yeah, I mean, so I do think there's a couple of things around this. So one, if you look at some of the evidence around some of the ambient scribe technologies that have been introduced, and actually, at least the initial evidence suggests that it doesn't really improve efficiency. If it does, it's like a few minutes, per day. What it has done, I feel like, is that it has opened up the space for doctors not to have to worry about note writing and note taking in the kind of exam room, talking with patients and about what that information looks like. And so a lot of people and a lot of physicians will say they actually have better experiences, talking to patients, et cetera, within that because of that. So my hope is that a lot of these tools exist kind of in the, the ambient space, et cetera, so that we're able to have more human contact. If you think about it, like what happens right now is that we spend a very little amount of time with patients because we're always doing all these other data entry and heavy cognitive tasks and putting in orders, et cetera. So my hope is that it's the reverse, that we get some of that exposure. But I will recognize that you could move towards that. But I think that then starts to really fundamentally change what it means to be a doctor and what the training would look like in those types of scenarios. We don't do a lot of really good humanistic training at this point, and I think we probably will need to shift as we move forward.
Thank you. One more question?
Yep. Really quick. So you talked about A/B testing, and my question is,
with those adversary red teaming kind of testing of what do you really what is really done there?
You're saying for the agent parts or just like A/B testing in general.
Yeah.
So I mean, you can think about like a clinical decision support tool that like even that UTI clinical decision support tool has like multiple different components to it, right? So the information display on it is one part about that. So and even that is probably worth talking about. Like, do I present predicted probabilities to physicians? Do I present it as just a low, moderate, high risk? Like, how do you convey that? So you can think about, you could alter and iterate all of those things. You could do that in the real world too, but you're going to spend years like trying to get all of that into place. And this allows you to be able to do that very quickly and rapidly and get some preliminary results off of that.
Awesome. Thank you very much, Andrew.
Yeah, thanks.